for kind words, and absolutely, it is very much appreciable the efforts that have been made by our earlier office bearers, Dr. Okshida, who is currently also Vice President of IABP, and she has done a wonderful job during her tenure as Honorary General Secretary. As a part of connecting to the people, it started all in COVID, following COVID, and we are still continuing with the same. And this is the most cost effective way to get connected to each other. And that too, once you are at your clinic, home, or even driving, you can learn. So, this is how it goes. And the topic for today is absolutely spot on, I suppose. And there is always time to learn and relearn certain things or unlearn certain things which probably have changed over the period of time. That is how medicine goes, how psychiatry goes. We need to keep on changing with time as the things get updated. So today we have two important people with us who are the speakers. They will be introduced by our chairpersons, and our chairpersons are very much familiar. Both are good friends of mine. And if I talk about Malay Dave, Dr. Malay, are you there, or he is joining after 5-10 minutes, as you said? So Dr. Indu is there as well, and Dr. Malay Dave, you may see him later on. He's a very vibrant, very active person from West Zone. He's a consultant psychiatrist in Mumbai with more than 20 years of experience. His area of interest is neuroscience and genetics, and he has held many positions in the organizations like Bombay Psychiatric Society. He was the president. He is a member of the IPS UG Education Subcommittee for 23-24. He has awards and honors to his credit, like Bombay Psychiatric Society Silver Jubilee Prize. That was won in NSIPS Bhubaneswar very recently. Then Dr. Anil V. Shah Best Paper Award in the 29th annual conference of IPS West Zonal Branch that was held in Mumbai in 1998. So then followed by that, we have another very well-known psychiatrist from our south of India, the other part of the country. She has done actually the degrees are numerous. She has done DNB, she has done MPhil in clinical epidemiology, she has done PhD from Government Medical College, Thiruvananthapuram from University of Kerala. She is working as a professor of psychiatry right now at Government Medical College, Ernakulam. She has won many awards. One of the prestigious Marfatia Award of Indian Psychiatric Society that she won in New Delhi in 2011. She has won prizes, first prize in the poster presentation category in Nimhan's Knowledge Conclave in 2016. She has been editor of Kerala Journal of Psychiatry, member of editorial board of Indian Journal of Psychological Medicine. She is a reviewer for international, national, and state journals and has published many papers in international, national, and state journals. It is over to you, the two well-learned chairpersons, Dr. Indu and Dr. Malay. I hope he will join subsequently, or maybe he has joined meanwhile. Dr. Indu, can you take over and introduce the speaker and the chairpersons?
Thank you, Dr. Martins, for those kind words. At the outset, let me thank IABP for having given me this honor of chairing this session. And there's some, it was Dr. Malay who was supposed to introduce the speakers. So I don't have the details of the speakers. If that is provided, or somebody else can please introduce the speakers. The task that was given to me was introduction of the topic. The topic today is psychiatric history taking from a biological perspective. History taking has been has a very important role in psychiatry, and I wonder whether we are losing that skill. It is an art, and I wonder whether we are losing that skill fast. So it is the right time that the Indian Association of Biological Psychiatry thought of taking up this topic of psychiatric history taking from a biological perspective. When the new residents join, we take all efforts to ensure that they take this up seriously, that any patient presenting with a psychiatric problem we have to rule out organic causes for that. And we insist that the prehistory of present illness should conclude with any history suggestive of organicity. So the speakers will be delving into the details, so I'm not going into the details of all that. But another area of interest for me is geriatric psychiatry, and I feel that there is one area where this biological perspective in psychiatric history taking becomes very significant. Patients can present with cognitive symptoms. In that case, any elderly patient presenting with psychiatric problems, you have to think of the possibility of organic causes. You have to think of the possibility of a neurocognitive disorder. So you have to rule out the history itself. You have to focus on the cognitive dysfunction. So the history becomes very important there. Not only memory impairment, other cognitive domains, how you can elicit the history suggestive of cognitive dysfunction. That is very significant. I hope the speakers will be touching upon all these areas, differentiating functional neurological symptom disorder from a true organic condition. All these requires a detailed history taking, and I hope the speakers will be giving the details and not taking up too much time. If the details of the speakers can be provided, or if Dr. Malay has joined, he can take over. Manjit sir.
Ma'am, I think we can continue. I don't think we need a big introduction. I'll just introduce myself very quickly that I'm Dr. Ritwick Chatterji, psychiatry, and after that I did a fellowship in child and adolescent psychiatry. I'm practicing in Pune and I'm in private practice. And Nachiketa, I think, will be okay with introducing himself as well. So if you're okay with it, then I would want to start.
I think that's so nice.
I think we can go ahead to the topic.
Yeah. I think we can go ahead. It has been so nice of you, and that speaks volumes about you that you're introducing yourself means it is a very good gesture, but at the same time, we acknowledge your what you have been doing so far, and I think you can continue with your presentation.
Thank you, sir. Okay, so hello everyone. I'm Dr. Ritwick Chatterji, and I'm going to be talking to you about psychiatric history taking from a biological perspective. Okay, so the context of this is that basically investigations in psychiatry, as well as treatment in psychiatry and examination in psychiatry, has been evolving. When we look at investigations, we have grown from just taking basic blood tests to having structural imaging like CTs and MRIs, to functional scans like fMRI and PET scan, and even to whole genome as well as whole exome sequencing currently. When we look at treatment, psychiatry has evolved to an extent where we are using multiple treatment strategies involving medicines, electrical stimulation of the brain, therapies, as well as lifestyle changes. Even in examination, a psychiatric resident currently is expected to be able to do thorough examination of all systems and a detailed examination of the neurological system, as well as even fundoscope. But when it comes to history taking, we follow the same format that our teachers used, and they followed the same format that their teachers have used. Perhaps if we compare only history taking, it may be very difficult to differentiate between history taken right now by a resident with a student in 1990. And that's why me and Nachiketa thought about this topic, and we thought that perhaps history also needs an upgrade at this time. So firstly, just a small bit about history. Now, history taking is the basis of medicine. Good history can clear the fog surrounding a disease or a syndrome or a disorder. Examination and investigations are helpful. They can help confirm a diagnosis, but history is always the most important part on which a differential diagnosis is formed. So let's compare. When we look at history taking in medicine, They look at demographic details, chief complaints, detailed description of chief complaints, including diurnal variation, aggravating factors, relieving factors, and associated factors with each symptom. They also check all the systems and not just the primary system. Negative history is given a lot of emphasis in medicine as well as past medical history. If you look at pediatrics, they talk about demographic details, then chief complaints, birth and developmental history. Then there is a detailed description of development with age and how symptoms evolve with age. Then they talk about systemic history, past history, as well as negative history. When we look at neurology, they talk about demographic details, chief complaints. Then they talk about detailed description of neurological complaints, including diurnal variation, aggravating and relieving factors, and associated factors. They also check all the other systems, not just the neurological system, and negative history as well as past medical history is taken. Let us just take a look at our current history taking format. Basically, what we divide it as basic demographic details, chief complaint, history of presenting illness, which we are talking about the current episode, past history, which are the previous episodes that the patient has had, family history, and personal history. When we talk about demographic details, few data points are name, age, sex of the patient, education status, employment status, relationship status, socioeconomic status as well. And it always makes me wonder why we do this, because again, a few of us, when we go into personal history, we talk about all of these things, and I feel it might be redundant to mention it twice. Okay, so talking about chief complaints, the issue that I have with chief complaints is currently we are focusing on only the current psychiatric complaints, and perhaps less importance is given to comorbid medical illnesses. Perhaps there's scope to look at other systems as well and look at an overall picture of health rather than just focusing on psychopathology. Examples for that would be something like GI disturbances, which are extremely common, or autoimmune or skin conditions, which are quite common in our history. Now, talking about history of presenting illness, this is the majority part of history. And I always wonder if we give undue importance to the cross-sectional view and we tend to underestimate the longitudinal view. So there is one thing that current diagnosis in psychiatry are syndromes. Basically, they are based on symptoms and they are also statistical. So as well as being cross-sectional, so what happens is we frequently see in our practice that when a patient is seen at different points of time, different symptoms manifest, and because of that, different doctors may give different diagnosis to the same individual. So while we're still trying to understand, I feel we can try to look at things longitudinally and find out consistently present findings and their variable presentation. Now, in my residency, the seniors used to tell us that history should be like a story. It should be something that is easy to listen to and it makes sense. But I always wonder if history should focus more on finding patterns of pathology, and that may make it more structured as well as logical. Talking about past history, here I feel that sometimes it is less importance given. And when coupled with present history, it tends to concentrate only on similar features. Giving an example, when we are talking about a case of bipolar disorder, what we typically do is we then make a graph about it, and we talk about how there are hypo or manic episodes or depressive episodes. But I always wonder whether if we present it like this, are we missing the elephant in the room and trying to fit all the information into a box, and that box is basically bipolar disorder. So that is another issue that I feel that our diagnosis tend to not be very accurate, and our history tends to kind of package the whole information into places where we can reach a statistical diagnosis, which may not be very accurate. Okay, family history. I feel that we should at least be taking a 3 generational family history. And I feel that we frequently miss history in terms of illnesses in other systems. In personal history, now this is something which is very unique to psychiatry. We go into depth about personal history, but what I've seen frequently is that this can vary in detail. With someone writing just a single sentence about the history and someone writing an elaborate history of each life event. And I always wonder whether we are focusing on the wrong thing or whether we are missing details that are actually important. So to summarize, when comparing history taking of other branches, what medicine does better is take into consideration all the systems in every history. Pediatrics, it does a good job at longitudinal history to give a picture of the child from the prenatal period till their age and basically help us understand how the symptoms evolve for the child. Neurology also takes symptoms of other systems into consideration, while psychiatry history is unique in the fact that we focus a lot on personal history. However, what I feel is good history would consider all these factors and more. And with our current knowledge, it might be a good idea to broaden history taking, consider more factors, and look for pathological patterns in every system. A couple of disclaimers. We know very clearly that what we know is very inadequate. Currently, we are still at a syndrome level, and we have not yet gone from a disorder to a disease level. With current information, we can only assume that we are basically the blind leading other blind. And what we do understand is that we need to restructure history taking and make it more logical. And we need to look at the longitudinal picture a bit more. Thank you to the organizers as well as the chairs. Thank you to the audience as well for listening very clearly. And I'll give it over to Dr. Nachiketa now. I'll stop screen sharing now. Yeah. Dr. Nachiketa,
Hello,
I'll hand it over to you now.
am I audible?
Yes, Nachiketa, you're audible.
Hello.
You're audible.
Yeah.
you're audible. We are waiting for your power.
So, good evening, everyone. Due to the time constraints, I would straight away move forward, share my screen, and while doing so, I'll continue talking. As the context is set by Dr. Ritwick, I'll be taking forward the discussion. And just I saw a message in chat mentioning about specifics. Yes, that is what I'm about to start focusing on. And this is my presentation. So I'm Dr. Nachiketa. I hope my screen share is visible. I'm a practicing psychiatrist in Navsari and trying to understand our subject better and from more biological perspective. So ideally, I would like to consider history from conception to last, whatever the current patient's age is. But that would be too jarring even for patient because they are coming with some symptoms and we at least need to listen to them about their current distress and what are their target symptoms. So trying to make a composite of what Dr. Ritwick has talked about, borrowing good points from neurology, medicine, pediatrics, and coming up with a template of sorts that can collect data while not disrupting the interview process or history taking process too much. So as we know, the main common points are basic details, history of current and past symptoms, preconception to current age, and other factors that we'll understand one by one. But something I would like to mention is regarding the personality. As such, we are trying to focus on longitudinally stable, consistent patterns of presentations or behaviors or symptoms. So those traits are what we are focusing on through and through. But we are more accustomed to this history of presenting illness, past illness, and personality at last. So I have tried to keep it that way. Otherwise, while taking history, I am thinking about all those points from the first interaction with patient. Basic details, as we all know, demographics, educational details, income, marital status, who are the other family members, what is the patient's position in family. Then comes the main point, why has patient come to us? Let the patient talk, recording the symptoms in patient's own words, and the usual ODP, how did it start, what was the precipitating factors, how long it has there been any treatment or not, what was the response to that treatment, if there was a discontinuation, why, was it symptom free after the discontinuation or not. These things we already know, but at the same time, we would also focus on biological precipitating factors. For example, many times our anxiety, depressive or the symptoms starts after flu-like symptoms. That should bring up the differential of encephalitis. So this is what I've meant, that as the interview is progressing, I'm also keeping traits in mind. At the same time, also considering correlation with other symptoms. Then comes the major bulk. Once the patient has shared his distress or her distress, and we have assured that, okay, we'll do something about it. Let us understand the situation better, if you can. Now, this longitudinal history from preconception to current age may not feel very relevant to patient. So it reflection, but the overall approach should be that we have this template and we'll try to fill up the details as and when they come up. And by second or third session, we would have sufficient data to form a longitudinal picture. In preconceptional level, we would talk about previous maternal history, previous pregnancies, whether mother had eclampsia, preeclampsia, gestational diabetes, hyperemesis, essentially any form of difficult pregnancy, because abruptio placentae, hyperemesis, preeclampsia, these have known correlation with our psychiatric conditions, especially certain traits in mother. Let's say anxious or distressed mother would have a difficult pregnancy, which is usually attributed to psychological stress, but we can say that the same underlying diathesis is leading to the psychiatric symptoms as well as the other symptoms. In case of fetus, fetal distress, intrauterine growth retardation, intrauterine death, there may be abortions in past, and then the maternal health just prior to this conception, whether she had good nutritional status, any symptoms of malnutrition, anemia, any non-communicable diseases like diabetes, hypertension, allergy, asthma, maybe there is coagulopathy, if there is rheumatological issue, young females may have certain issues, even in neurological multiple sclerosis can be there, and the infections, including HIV, STDs. Apart from this, obviously, we would be asking about mother's mental health, any known symptoms, whether she is on treatment or not. If she is on treatment, what kind of treatments, whether this pregnancy was intentional or a result of failed contraception or a form of unwanted pregnancy. Once the mother has conceived, whether first trimester was comfortable, did she have the same symptoms that she did in previous pregnancies, or there are new symptoms? And usually that hyperemesis and spotting are common in first trimester. By second trimester, again, hyperemesis, spotting, fetal distress may be there. Amniotic fluid volume changes can be there. There can be delayed kicking or maybe failure to perceive quickening soon enough. In third trimester, primarily the issues would be related to contraction, labor, false labor. In terms of fetal issues, there can be fetal distress, IUGR. At the time of delivery, there can be issues with delayed onset of labor, prolonged or obstructed labor, whether the delivery required cesarean section or not, whether there was need for forceps delivery or not. the baby, whether she cried immediately at birth or not. If possible, nowadays documentation may be available with the cards and all those government schemes also. So we may have documented finding of low ABGA score. There may be NICU admission, primarily for neonatal jaundice or kernicterus, whether there was difficulty in breastfeeding, and just like not crying at birth, whether the child was crying excessively, is there any history of major infection or bleeding tendency in neonatal days? So all these histories primarily almost same as a child or OBGY history, but they do have significant relation for us also, because the what we consider as a childhood neurodevelopmental disorder. In broader terms, we tend to see that there is a neurodevelopmental trajectory, and that beyond a certain point, there is neurodegenerative trajectory. So any form of deviation from this trajectory of what is expected normally can be hinting at underlying traits and can help us understand whether the person is prone to future psychiatric symptoms or not. And that aspect is almost same as the growth charts we see in pediatrics, whether the deviation is between 2.5 to 97.5 percentile or not, beyond that. Only thing is, pediatrics have norms and their data is available that this is normal. We still have to figure out our normative data. But the concept is this, and we can simply try to understand whether the child is having the developmental trajectory appropriate to age, or it is deviating significantly, just like we see in autism and other neurodevelopmental condition for now. But it should be extended beyond childhood. So what next? Neonate to 6 months. Even in this young age, there can be pointers. Say one pointer mentioned here, delayed social smile to mother. It can be visible as early as 2 or 3 months and can be indicative of future propensity for autism. What other things can be there? The difficulty of breastfeeding that was there in initial 4 days may continue. There can be delayed establishment of sleep-wake cycle. We usually expect that by 2-3 months, baby should be awake in daytime and sleeping in nighttime. But this child is staying awake at night, sleeping less or sleeping more daytime. Whether if the baby is awake at night time, if the baby is cranky or playful, whether we cannot be put to bed easily, parents are getting tired, or the baby is very lethargic. As mentioned, delayed social smile to mother, excessive reactivity to environmental stimuli. This can be noted in form of excessive crying or startles in response to any loud sound and such things. How many times the baby required breastfeeding, whether there is regurgitation of milk after feeding, whether there is burping after feeds. These are very early, because the one thing that we can understand is when the child is young, there are limited forms of expression and presentations. As the person grows up, there are different varieties or forms of expression possible. That's why we consider broadly internalizing and externalizing behaviors in childhood. But as the person grows, we sub-classify into different symptoms. From 6 months to roughly 3-year or preschool age, there can be delayed milestone. The usual history is suggestive of intellectual disability or maybe development in social and communication area is lagging behind. Language development or verbal development is poor. Baby is having difficulty in recognizing parental expressions. Whether baby is about colors, textures, sound, even people crying excessively in presence of certain people or absence of certain people, which later gets extended as stranger anxiety and separation anxiety. Extreme irritability about things out of their choice routine. Even toys and other things, they would want it particular way, getting frustrated, throwing things around, which might seem very simple and silly to us, but that also indicates this obsessiveness about routine and sort of inflexibility. There can be repetitive behavior, stereotypes in terms of ADHD and stimulating behaviors. There can be breath holding spells, blue baby, white baby syndromes. There can be, as mentioned, separation and stranger anxiety. Again, the excessive reactivity to stimuli continues from 6 months to current age also. We may be able to notice proper attention deficit symptoms or hyperactivity. There would be clumsiness, frequent falls. Baby may also have prolonged breastfeeding. One or two cases I recall seeing in my internship during pediatric days where I saw a baby breastfeeding at 5 years of age, which is quite unusual, deviant from norm. No, so whether it was right or wrong, no, it's a symptom. Why is it happening? Whether baby is clingy, what is happening? There can be frequent infections, as mentioned by Dr. Ritwick, upper respiratory or GI infections. Otherwise, also GI upset. Colic is common diagnosis by pediatricians in this kind of presentations. And at this age, now slowly we are seeing the organization and arrangement and symmetry related symptoms. As child starts schooling, when did the child started, whether it was directly school, first standard or preschool, whether there was crying in school, how many days, how severe it was, did parents have to sit outside, what were the measures taken to manage it. After few days or weeks, when the crying reduced and child adjusted to school atmosphere, how was child's interaction with peers? Was he or she solitary or like to interact with others, or was not sitting at one place, disturbing others? So this can give us clue about initial history. This would already ask in autism and ADHD related history taking. Whether the language acquisition continued further or not, general fund of vocabulary and knowledge improving or not, how is the interaction with teachers, whether very fearful, afraid, all those stranger anxiety, separation anxiety things, did they phase out or are they continuing even now? One new thing starts, fine motor in terms of writing skill. Does he show any form of specific learning disability related symptoms? How is the child's conceptual grasp? Then comes primary and secondary pre-teen years. So now slowly child has started showing more adult-like symptoms in terms of anxiety, various fears related to animals, tantrums would start, stubbornness, GI upset may continue, allergic tendencies would be present, particularly in winter season. Upper respiratory are common allergic rhinitis and other things. Did child develop and acquire sufficient social and communication skills to have interaction with peers? How are child's childhood friendships? Can he manage frustration, or is he getting into fights frequently? What is the nature of play? Whether it is repetitive, whether he is able to complete one activity with focus or takes one task, puts it down midway, changes to other thing, which is indicative of attentional issues or hyperactivity. There may be acting out in association with tantrums, throwing things when frustrated or during the tantrum, excessive anger, difficulty in controlling these emotions. There may be nightmares or sleep-related behavioral disorders, sleep talking, nocturnal enuresis that should have been over by this age, still continues. There may be encopresis, which is usually seen somewhere around 3 to 6 years, but it can be present at later age also. There may be emergence of proper OCD type behaviors along with what we traditionally diagnose as internalizing and externalizing behaviors. They are essentially acting out or avoidance and related things. As mentioned, prolonged breastfeeding. There may be other pacifying behaviors, nail biting, thumb sucking. There can be stuttering, stammering. Now, when we focus on this from biological perspective, it may be too much at this juncture, but we can try to associate why is this happening. There is a concept called there can be behavioral and motor parallels. Let's say if person is having stuttering, stammering, there is difficulty in fluency of speech. I would also look at the incoordination, clumsiness, and fall related issues. They may be originating from same kind of the CNS activity or circuits. Then comes the period of teenage. As we all understand, the amygdala and emotional brain part has matured more, but the prefrontal control is still not adequate. So impulsivity would increase and related things would be present, impulse discontrol and the acting out things, low frustration tolerance, risk-taking behaviors, promiscuity, substance use. Along with that, biologically speaking, one major area is puberty, where there can be issues related to menarche and irregular menses. This may be early indicators of something like evolving neuroendocrine issue, let's say PCOD or some other things. Even just simple late or precocious puberty may be indicative of many things. There are many congenital errors, hormonal and errors of metabolism, which can be associated with this early or delayed puberty. So this crucial period is first period of transition where body is changing from child to adult physiology, and then the other period of transition would be in middle age, that we'll see later on. And during this pre-teen to teenage, this transition phase, and the 45-50 range, the other transition phase, we see peaking of incidences or prevalences of almost majority of non-communicable diseases, including psychiatric disorders. This is the bimodal peak distribution. And that is the interesting parallel that we see case of, let's say, depression or mood disorder or schizophrenia. Onset in teenage years or childhood is considered an indicator of severity, or in more traditional terms, it is an indicator of more of endogenous or biological roots of that particular person's disorder compared to just a psychological distress. So what other things can be present in teenage? Self-harms, suicidal or non-suicidal, both. There may be fanaticism, extreme obsessive thoughts, and coupled with the impulse discontrol issues and aggression, what we can say impulsive, compulsive, aggressive phenotype. This is neurobiological phenotype. We are still at symptoms and syndromal level, but at least this impulsive, compulsive, or impulsive, impulsive phenotype stays lifelong and presents as different disorders at different ages. So if this kind of presentation is there, there is high likelihood of person deviating towards conduct disorders, crimes, fatalistic acts. Another important part is migraine with menarche and other things, especially in females. There is a dictum that migraine increases after menarche when menses starts and stays till menopause, and after that reduces in frequency. So these are the broad strokes. I am not going into each and every detail. My focus is more on the template or heading and approach rather than each individual detail. In early adulthood, let's say there is what we talked about. We are not limiting the neurodevelopmental lens to just childhood. Let's say a person with ADHD. In a sense, it is delayed maturation of prefrontal control. That person would present at this early adulthood as more of impulsivity, forgetfulness, anger issues, impulse control disorders, behavioral addiction, substance addiction, rather than just hyperactivity. As we know, hyperactivity subsides with age. But then these things tend to fly under the radar or miss out in history taking, and that person may get label of, let's say, soft bipolar. But whether he is actually fitting in bipolar 1, bipolar 2, or is he fitting more into trait, mood lability, high emotionality, impulse control issues, that would decide his future interactions with the same and different psychiatrists. Because let's say somebody has considered bipolar NOS or soft bipolar. The other psychiatrist seeing the same patient 10 years down the line with that old record would think twice whether I'm actually dealing with bipolar or not. Let's say I'm thinking of impulse control disorder, I want to give SSRIs, but that bipolar tag prevents me. Was it actually bipolar or impulse control issue? Then the usual manic psychotic features can be the presentation, substance use, most of the times gets diagnosed as a separate disorder, but on the whole, it may be more of self-medication, and it may be hiding the underlying other conditions and traits, particularly impulsivity and ADHD-related things. In case of females, there may be pregnancy and pregnancy-related issues. The whole psychiatric OBGYN interface comes into picture, infertility, difficult pregnancies. This would be the preconception history for next generation. Then there would be few years of relative plateau, symptoms come and go, there is improvement, there is again relapse, and slowly we come to that second transition phase of middle age. At this age, actually, genetically, there are changes, some genes and epigenetic changes show their effect, and there is actual transition happening to geriatric pathophysiology, and slowly the kind of decompensation would start in geriatric age, but the early trailer of that would be visible in middle age. The symptoms of low cognitive reserve in terms of easy mental fatigability, attentional or concentrational issues can be noticed. These are usually chalked up as menopause related or hormonal changes. In case of males also, now there is concept of andropause. There may be early change of inflexibility and what we call geriatric rigidity. There would be onset of other non-communicable disease as the second bimodal peak. Rarely there would be early or very early onset symptoms of neurodegenerative condition. Let's say behavioral variant frontotemporal dementia. We expect onset at 55, but in some cases there may be anticipation and there is onset at 47, 48 also. Although it is rare, but we do need to keep this in mind. Another example is Down syndrome, where it is documented that those people with Down syndrome either don't survive till very late, or if they do, they have earlier dementia, almost a decade or two earlier than other people without Down syndrome. And this is not limited to just psychiatric history. Even we see osteoarthritis and other changes, and even non-medical people understand this and they would start saying slowly, abhi umar ho raha hai. So all these are wear and tear that the language is very easily understandable to a general person also. Then in late age, as we know, we would primarily screen for dementias and associated neurodegenerative conditions. As Indu ma'am rightly said, we need to focus on organicity equally or probably more than psychological factors. Not to discount the psychological distress, but there is this tendency to miss out on underlying biological aspects. So the geriatric rigidity, disinhibition, that may be early indicator of BVFTD. Disinhibition can surprisingly present as de novo behavioral or substance addiction, or appears like late onset manic episode, but it is actually disinhibition. And sometimes it paradoxically worsens with treatment as per mania. Person is getting loaded up by antipsychotics or valproate and getting more and more disinhibited, and then that gets label of resistant mania maybe. However, the moment there is clear description of personality changes, word finding difficulties, or other frontotemporal symptoms, cognitive symptoms, at that point we would definitely label it as dementia. But that at times takes long time, 65, 70, 80s. About 5 to 10 years before that, mild cognitive impairment, mild behavioral impairment, these symptoms may be missed as of being neurodegenerative origin rather than being, they would be labeled as emptiness syndrome or other psychological factors. Another area, parasomnias, let's say REM behavioral disorder, very, very common in Lewy body pathologies and related dementias. There may be new onset of diabetes, hypertension, dysautonomic symptoms around 60s. In cardiovascular, I can think of sick sinus syndrome, bradycardia starts appearing, needing pacemaker. There would be proneness to hyponatremia without medication or with medication. Then the medication gets labeled as the primary cause of the hyponatremia or SIADH. There would be proneness to delirium and a typical trajectory that can be seen is initially delirium is less common, maybe once a year, and as neurodegeneration progresses, cognitive reserve decreases, there would be frequent episodes of delirium. So all this history should ideally be collected over 2-3 sessions and should be summarized in a life chart or lifespan full details. This is more of a comprehensive life chart thing that I have borrowed from this one article. This tries to include locations on x-axis where patient has lived. Why is this relevant? Because sometimes local environment and changes also affect our physiology, but they do need to be extreme. Like for example, in this case, she moved from small town to abroad. Everything changes from diet to time zone to everything. And over the period of time, since childhood, what other things have happened across that particular patient's life to land up in impaired care at this age? That is roughly 45 or 58 as per this graph. Although this is focusing more on biopsychosocial model, but the same thing should be kept in mind, and we should try to make this chart for biological aspects also. And then we should include the family history. That was one of the query in checkbox. So minimum 3 generation pedigree history, patient, their parents, and all the siblings at the age. Look for any and all non-communicable diseases. We are still more of trying to explore and collect data and see the emerging patterns rather than predicting something. But there are certain patterns emerging. For example, high sympathetic tone would be presenting as impulsivity, aggression, maybe asthma-related issues, allergies, impulse control issues, substance addiction, hypertension, so like that. And the oncogenetics, malignancies, and hematological disorders. Genetics of malignancies and hematological disorders has huge overlap with psychiatric genetics. So these are maybe what we can say, same underlying diathesis, presenting as different thing in different people. So that is one thing. Now, how do we collect data? What I do in my OPD practice is I explain basics of genograms that I'll be showing in next slides, and tell them to just collect the data. Any disease, any long-term chronic issue that was treated or untreated, and mortality. How did the person pass away? And the psychiatric symptoms, including the eccentricities. With regards to eccentricities, I tell them that people would tell bad nature or odd nature or weirdo, vichitra swabhav, but there are different flavors of that. Here I am hinting at 10 different personality disorders in DSM, but then more in sense of how that person's behavior is deviating from what is expected for that person's age. So broader term is eccentricities regarding any history of substance use. And when we collect this data, we'll just explain them. Male is square, female is round, marriage is this joining line, demise is this crossed line, this double line is divorce. This is enough. They can then fill up the details. Sometimes they come with tables or charts, whatever way they understand. And then we can then translate those details into proper genogram. This is one real world example of a patient I'm dealing. The index case was 9-year-old male, brought to me with confusion. What is he actually having? Because he was being seen by 2 different pediatric neurologists or behavioral pediatricians. And one was saying that he is autistic and the other was saying he is ADHD. What I noticed was he is smiling alone, responding to internal stimuli. This worried the mother that my child is having schizophrenia. And he is receiving risperidone 0.5 and he is responding also. But what were the other symptoms? They are not able to explain clearly. Just he is different from others, throws tantrum, manipulative, lying, repeatedly asking same thing, repeatedly seeking reassurance. This was the child's presentation. But look at the history. This is the mother, this is father, this whole area is parent sibling, this is their parents, and this is 4th generation. Lot of history, anxious traits, There is ADHD-related symptoms, naughtiness, intelligence, but very aggressive, argumentative. There is history of self-harm. There is leukemia, ulcers, suicidal attempts. ADHD trait in mother also. Actually, mother's presentation is almost same as child, and she can relate that she also had school refusal just like child has because they had struggle with mathematics. Mother's mother muttering alone. It is more of ranting or sub-vocalization, not hallucinatory. Stubbornness, hoarding, untidiness, lies. This would have easily been termed simple schizophrenia cross-sectionally, but this is throughout her life, her personality. On father's side, there is mentioned narcissism, impulsive, aggressive phenotype. Father's father has alcohol issue, forgetfulness. There is high cholesterol in 2-3 family members. In grandfather generation, there is seizures in 2 of the grand aunts, stubbornness, Parkinsonism, even in great grandparents, OCD or probably OCPD, one of the two. Then one of the grand uncle was having seizure, forgetfulness, eccentric behaviors, had this habit of blowing, which maybe take us some OC spectrum related thing. Another one was this, that one of the aunts of father noticed as a layman that all of the boys in father's side tend to open up late. That is their word. What probably that aunt was trying to say is there is delayed social and communication development. Child trying to remain solitary and then later on learning those interaction and social skills. So having seen this, almost whole psychiatry is there, very, very high genetic loading on both sides. Now I could say that, okay, he's having some traits of autism type picture and some traits of ADHD type pictures also. On top of that, he is having high anxiety. And then as secondary to those high anxieties, he's having all those externalizing, internalizing behaviors or evasive behaviors, I would say, which is being labeled as tantrums or manipulations by mother. And the same anxious mother, obsessive, is also almost a helicopter parent. So this is the biological presentation. At this point, I am also thinking channelopathy. Whether this whole presentation fits in, let's say, TDP-43, or whether it's a form of channelopathy, I don't know. I don't have enough knowledge. But at least now I have some detail. And let's say if we have 100 such diagrams, lot many patterns would emerge. So,
Nachiketa, can
personality part that we
you
talked.
wind up quickly? We are
Yes, sir.
overshooting time. Thanks.
Yes, sir. So, why I'm highlighting this particular part, I want to look at the traits, but patient may not be able to narrate those traits. So, we would look at social relations, temperament, attitude to work and responsibility. This would hint at conscientiousness, interpersonal relations, energy levels. That would also give idea about temperament. And then we would translate this into biological constructs and ask clarifying questions and any other details, including sexual history, let's say addiction, sexual history, addiction not amounting to primary disorder, or let's say just substance abuse. This may be indicative of hedonic drive or mesorephilic drive, how they are fitting with biological constructs. And that would give us a lifespan picture of this particular brain, how that brain reacts in different situations. On top of that, what that particular person has learned by trial and error, how to manage things. So to conclude, longitudinal lifespan approach with focus on stable, consistent symptom domains, correlating those with other illnesses. Let's say, what are the symptom flare-ups, not just psychiatric, but also non-psychiatric. And 3-generation genogram are the 3 main takeaways for today's presentation. Thank you. I'll be stopping the share.
Thank you so much, Dr. Ritwick and Dr. Nachiketa, for that nice presentation on history. Shall we take some questions? We have got some time. We still overshot the time a bit, so let's make it quick. Yeah, so the questions that have come up are, let's check. Yeah. So first question was by Dr. Paramveer, and he asked about a brief explanation on taking 3-generational history. I think you gave a couple of examples, and I think that was very clear there. Second question is by Dr. Rehan, and he asks any specific case-related subheading to focus on. So if you are dealing with certain types of, in the history taking, when you are looking at a particular pattern and you are considering some diagnosis in mind or a differential, subheadings to focus on, what would you ask? Kind of, as I understand from the question, what kind of leading questions? So if you give if you can give one or two quick examples. I think towards the end of the, as you talked from birth till adulthood and geriatric age groups, or the aging and later age groups, you did mention about how disorders evolve and what can be, I remember very well, the early presentations of what can be clinically labeled as dementia, maybe a decade or 15 years down the line. But still, if you would like to give quick examples, both of you can give a quick example of this.
So I would request Ritwick Bhai to mention a bit about childhood and teenage, and some examples.
I think Nachiketa had given a very good example. For example, when we are looking at childhood disorders, if we are looking at two different trajectories, one trajectory is towards ADHD, one trajectory is towards autism, and how these evolve over age. And when we look at these same disorders at a say young adult age, with the ADHD like diagnosis, we tend to see a lot of substance use, lot of behavioral as well as impulsive, compulsive behavior. We look at a lot of risk taking. We look at a lot of say cluster B traits in personality. When we are looking at the autism side of the spectrum, we are looking at people who later on may get diagnosed as OCPD, or possibly as a cluster A diagnosis. Along with that, when these people tend to go into, say, a destabilization period, obsessions can be quite a bit. There might be some disorganization which will be diagnosed as early onset of schizophrenia. So I think these two are these two trajectories are very different, and we are able to delineate at least that much in the childhood areas. But we are looking at much more subtle trajectory differences as well. It's never as clear cut as someone having only pure, say, ADHD symptoms or pure autism symptoms. It's always a mixture of different things. And I think the example that Nachiketa shows, if we are able to do something like that, we should be able to delineate many more finer trajectories in between these two trajectories. Over to you, Nachiketa.
Okay.
So similarly, let's say an adult case comes, maybe the presenting symptoms is indicative of cross-sectionally depressive symptom with anxiety features, or somatic symptoms are common. So I would like to then evaluate a bit more what kind of trajectory is he having or she having. And at the same time, I would also like to club another question here regarding the questions to patient, because that would actually give me clarifying information that I would try to understand what patient himself feels about his own impulse control, difficulties he had in childhood, and what kind of brain function or hair function issues he is facing. Many would describe that I'm having trouble with mathematics, or I'm having navigational issues, or I'm still having right-left confusion. I need to take time to think, route to my workplace. these are subtle things, and then slowly, other clarifying questions would add on. Let's say if I am suspecting underlying ADHD traits that have continued from childhood, now presenting as anxiety and substance use, what other markers I can think of? At that point, I am also observing for, let's say, signs. Blink rate is one crude indicator. It's not very convincing, but something that I can note down that, okay, this is something that caught my attention. And then having an open mind and trying to understand, and it is very quick case by case, but broadly, I would try to understand how is the impulse control, whether patient has compulsivity issues, how is his working memory, forgetfulness things, and these kind of things. So clarifying questions would depend on that kind of situation and trying to understand how this particular brain is functioning. Because what happens is in psychology, we have different schools of therapy and each has their own case formulation. Similarly, in neurobiological aspects also, we have to have its own terminology and dictionary, and trying to look at those constructs and eliciting those histories by asking patient relevant questions.
Okay, so if I can just ask you this from my side. Now, when a patient comes alone or when a patient comes with, let's say, an unreliable person with him and who doesn't know much, of just a friend comes, so we are going to always end up with not a complete history, not an ideal history, but maybe something more than the cross-sectional history. So do you think in such patients, when we look and assess for something like dysmorphic features, soft neurological signs, mild cognitive impairments, not the mild cognitive impairment as in dementia, but the mild cognitive impairments that
Yes, sir.
have happened as a part of development over time, if you can ask some questions that would be useful, because by themselves soft neurological signs have no I mean, they do not have localizing value, and by themselves they are not important, but in the context of the in context of a particular set or a pattern of symptoms going on, they become important. Another thing that kind of sum up a lot of things that you mentioned, especially in children, is what we used to call something as temperament. So the list of basically 9 parameters, and how a child has performed on that could also be a quick assessment of many of the things that you mentioned. Another thing is, I mean, we didn't go into a lot of examinations, but yeah, so this kind of things can be helpful additionally when we have limited data.
Yes, sir. I think it would be very helpful to think about associated features, look at different diseases in different systems as well, just like we are looking at, say, dysmorphic features. This could also give us some better idea about the trajectory when we are only looking at the patient's history. Although the thing is that me and Nachiketa, we felt that this topic was too much to do at one go, both history and examination part. But I think someone would want to cover the examination part as well as dysmorphic features and everything else, possibly in the next lecture.
Okay. Another thing is when we look at a clinical history, and as you mentioned in your presentation, that we look at symptoms, because that is what, when somebody tells me that I am stressed or I'm not able to sleep, we get into symptoms directly. And I think when I'm telling you this, I am also making an attempt to Dr. Khera's question, which is the last one. How would you formulate current history of chief complaints, history of presenting illness in a biological context or language? Because the problem that happens is symptoms that in psychiatry are actually words that are found in the English dictionary. And so there is always going to be interpretational error. For some people, getting minor upset is depression, and for us, depression is something totally different as an illness. So in that regard, how useful do you think something like what is mentioned in RDoc would be? Because they straight away get to the underlying kind of mechanisms or broad endophenotypes or possible mechanisms beneath the level of the symptoms. Would you think that would be a more robust kind of so instead of saying that patient gets upset easily, we have we have a term that is given by Aarambh that will make it more meaningful in the neurobiological context. So the question is, coming back to the question, how would you kind of formulate the current history, current episode, or history of presenting illness in a more neurobiological format? Because at the end of it, below the symptoms is an endophenotype. Below the endophenotype is basically a group of network, a network or a group of circuits, and below that are neurons and cellular processes. Below that is genetics and epigenetics. So this is probably how the thing works. So looking at symptoms, we can get some information, but what we need to probably look at is what is leading to these symptoms. And what I understand from the history, from what you people mentioned, is that once the mechanisms are understood, it will make more sense. When it comes to formulating treatments, our interest in taking a detailed history is formulating treatments. Patterns are there, but what is the underlying basis of these patterns? That is also an important thing. We can have n number of patterns, and as you mentioned, that DSM diagnosis is statistical. What is the probability of all these things combining together to form a syndrome? But without an understanding, we'll still be dealing with probabilities. So if we have something like this, so the question is, how would you kind of formulate in a biological context the language that needs to be used? So that is where it struck me that what are we doing with Aarambh? Is it helping us, or it is a waste of time? Do we have anything better, more relevant?
If I may.
Yeah, sure.
Yeah, so again, this is more of a reflective answer, but it has some practical applications. So there is one top-down approach where we go symptoms to underlying etiology, and then there is another opposite approach, bottom-up, where we look at genes first and then what effect it has on proteomics and other things, and how they affect the organ structures and functions, and then how they present as different endophenotypes and so on. However, that is in clinical practice, somewhere we have to, start a little bit on this and little bit on that and see where they are meeting. I may have some theoretical knowledge about something like channelopathy, and I know that, okay, particular that XYZ calcium or potassium channel is presenting as these symptoms. Now my patient is having this. Are they fitting? Are they matching? If they are, then I am having some kind of rough model in my mind. Number one, I would think not in terms of neurotransmitters, but in terms of neurocircuits. I would consider that no brain function or no brain area is singularly involved in one particular brain function, nor a particular brain function is handled by single brain area. So let's say stuttering and clumsiness, and it has behavioral correlates. So I'm trying to think maybe he's having some kind of basal ganglia issue or not. So I'm trying to translate at least symptoms and phenotypes to first, for our convenience, certain brain functions and brain regions maybe, and then seeing that how that what circuit is probably disrupted, because then we need connectomics, and which is not doable in clinical practice, but at least we can apply that knowledge this way. And sort of prediction, say if a person is having tics, does he have motor correlates? Are those symptoms present or not? And the terminologies very rightly said that we need to have terms that are being used in neurosciences and how they're specific to the condition and not taken from general English dictionary. They are subjective. So I would try to look at how this particular brain functions and where is that brain struggling. What kind of dysfunction I'm expecting? Is it response inhibition issue? Let's say even impulsivity is a construct and it has subcomponents and other things. So one older model was to look at perseverance, whether a person is able to persevere with a task or not. If there is low perseverance, it is impulsivity. If it is high, difficulty in letting go, it is compulsivity. But then it was found out that impulsivity and compulsivity may actually be two orthogonal separate domains. But that is the confusion that occurs. And with regards to Aardok, what happens is that it started ground up to build new neuroscientifically oriented vocabulary and symptom domains. That is why we see terms like positive valence system and negative valence systems and other. But over a period of time, somewhere maybe the process of validation or something, it is now again going more towards biopsychosocial model. Although biopsychosocial model is inclusive, but one of the limitation may be mentioned is that it is too broad, and to be extreme, I can say anything goes. Throw any data, it will fit somewhere, either biology, either psychology, either social. So we need to be more specific. And yes, we don't have all the data at this juncture, but at least we can have the lens and approach. Then we'll get better data, more reliable, more consistent. And then we can move forward in more etopathological and biologically oriented direction.
Okay.
If I could add a couple of points to this, sir. So number one is that, like you said, we are looking at behavior, which is probably an output of different circuits, which is probably an output of different cells working together, which is probably an output of things happening at a genetic and epigenetic level. So I think what the issue is that unless we are able to connect all of these together, it will always be an incomplete picture. So I think where Aardok might have failed would have been in not trying to connect all these levels together. The other thing that I would comment is when we are looking at the brain, it is the most personalized organ in the body. And we know even for, say, identical twins, their brains would be different in the way that they function. So now we are not only facing the issue of vocabulary, like we are using English terms, but also whether the same term for one brain would translate into the same term for another brain would also be something which would always be in question. So I think maybe what we should be possibly focusing more on is patterns rather than in terminology.
Okay. Madam Indu, I would request you to
Yes,
comment.
this I feel is a new attempt at looking at things from a different angle. And one comment that I would like to add, as someone was mentioning earlier, the focus on child and adolescent part, the neurodevelopment, you're focused on that, and that is, I think there's a little bit of bias towards that. So I think that has to be rectified. So this definitely is a new beginning. And I think more work has to be done on it. And I think other people should also join the discussion, and this should be elaborated. And I think this is a very good effort.
Thank you, ma'am. I think we have overshot our time a bit. We hand over the proceedings to the organizers.
Thank you, sir. Dr. Majid, are you here, sir?
Yeah, I'm very much here.
Okay. Would you like to make some final comments before I present the vote of thanks?
I think we have already overshot the time, as I respect chairperson's words, Dr. Malay, and I think it's time to be vote of thanks.
Yeah, maybe we are holding people from their dinners.
Yeah, hostage.
Yes. So at the end, I would like to thank, on behalf of the Indian Association of Biological Psychiatry, our very distinguished chairpersons for the day, for the evening, Dr. Malay Dave, sir, and Dr. Indu. Thank you for your, I think, very able handling of the sessions, as you always do, sir, and ma'am. And our special thanks to our speakers for the day. As madam also pointed out, you actually provided us with a different perspective to history taking biologically. as that is our objective in IABP. So thank you, Dr. Nachiketa, and thank you, Dr. Ritwick, for your presentations today. I would also like to thank our office bearers. Dr. Majid is here. Thank you, sir, and other office bearers who have helped organize this first Friday CME for a very long time. Thank you to the persons who are responsible at the IABP office, Amitaji and others, for holding this seamlessly. So thank you all. Have a good night, and we'll see you next month as well. Thank you.
Thank you.
Thank you.
Thank you.
Thank
Good
you all.
evening.
Thank
Good
you.
evening.
And thank you, Manushree. Thank you very much. Malay, thank you so much. I introduced you. You were not there, and in
Yeah,
your
I was.
absence, I
Yeah.
introduced.
Yeah. Thank you so
Pleasure to
much.
introduce you. Thank you so much.
Yeah.
Good night.